Today we're actually going to have a discussion about case management for individuals who we define as high need and high risk, and what the different models are and how to sort of integrate the risk need responsivity framework model into the practice of our sort of case management. And before I start, what I'm hoping to do is define high risk and high need, sort of talk about case management in responding to behavioral health needs, which is substance abuse and mental health, and then talk about the challenge that we have in also making sure that the sort of case management, whatever model it may be in terms of your case management, is also responding to sort of the risk framework. And so we have the framework, and we're sort of in this session really sort of seeing how everything is going to be sort of integrated together. But we're going to have a discussion. It's not a very long presentation, and the idea of this breakout session was for us to really sort of have a discussion about what people are doing in practice, in different jurisdictions, what you hope to do in practice to sort of answer questions. I know yesterday I was in the juvenile segment, one of the breakouts, where it was assessment and screening, and I was really thinking that I really wanted to have a didactic lecture from him because he had so much information, but the idea of this breakout session was really to have a discussion. So I apologize for that if you came expecting that I would be sort of just talking to you guys for an hour. So in defining who individuals are in terms of high need, it's about sort of diagnosis and functionality, and sort of the functionality that comes with the mental illness is one of the critical aspects that need is not just based on that you have a diagnosis of schizophrenia. It's also based on how your psychiatric diagnosis impacts your ability to function in the community, whether you're able to sort of work and function, maintain a full-time job. Clearly, even if you have a diagnosis of schizophrenia, you have less need than an individual who really needs sort of case management to help care coordinate their lives, whether it's getting to appointments, reminders about the need to sort of take medication, and making sure that the person is engaged in mental health treatment, helping with sort of transportation to get someone to the treatment entity, that the functioning of the person is really sort of the critical issue that we want to think about when we define people as being of high need. And the needs that our individuals, our participants may experience are needs that could be related to just other psychosocial domains. So they could be needs relating to addressing homelessness, needs related to addressing people's ability to have health insurance, people's ability to have income support, people's ability to engage in what we sort of describe as meaningful activity in their day, and so that they are sort of integrated in the community. And so for us, when we sort of run these programs, we need to think about sort of where do our consumers fall in terms of continuum of the needs that they have. And that's going to be, in terms of your assessment of the consumer, that's going to be the factor that's going to really sort of help you define like the nature of the services that you need to provide. And it doesn't matter whether you are providing the most rich sort of case management, evidence-based services around case management, which would be assertive community treatment for people with serious mental illness. And for those of you that don't know, assertive community treatment is an evidence-based model. It's comprised of a multidisciplinary team who are actually charged with going out to the consumer in the domains where the consumers live, because the consumers that need that level of service because of their high needs are not able to just go themselves and utilize treatment. And so on an ACT team, you would have a psychiatrist, you have nurses, you have social workers who have different functions. So you'd have a vocational specialist social worker, a family specialist social worker. You'd probably have a substance abuse specialist individual who's credentialed in addiction work. You may have peer specialist staff, so those people who are themselves living in with mental illness, who are in recovery, who are providing intentional peer support, which is sort of mentoring and peer support around how folks can improve their function and engage in recovery in the community. ACT is a very robust model of intervention with the people who are high utilizers of hospitals. We're seeing now that ACT teams are being rolled out for individuals who are also high utilizers of jails and prisons, known as forensic ACT teams. We're seeing that model more around, but many jurisdictions can't afford to have ACT teams. So you may have basic case management. I was in a session where someone was describing, we're about to hire the case manager who's paid for with this grant. That might be your reality. In case management, what we have is that in these types of programs, in sort of responding to need, we want someone who's going to be able to span systems with our client. So the person who's going to meet the client, whether in the criminal justice adult system or the juvenile justice system, who's also going to span with the client the sort of community, that they are able to be what we describe as a boundary spanner from whatever the incarceration, whether it's jail or juvenile justice, into the community, that their role is to navigate the system on behalf of the client, to be the client's advocate, to respond to the client's needs, so making sure that the client gets access to services, maybe what your grant allows you to do, what your program model is. That's fine. Do you know what I mean? Like, I would not be concerned about the fact that we're not doing evidence-based practice, we're not doing ACT. I know there was a grantee here who's doing an integrated dual disorder team, which is another evidence-based practice, but again, a very robust, a very expensive program. If you have one case manager, that person is going to be addressing the client's mental health needs, their functioning, and helping to improve, that the clients are going to get better. So whether you have someone that's a bachelor's level person, a credentialed mental health clinician, or if your case manager or maybe someone who's a peer specialist, that might be a peer mentor, someone who themselves has used the mental health system and has recovered. All of these folks can respond to clients in terms of their functioning. What we do know also, though, about our clients in terms of needs, it's not just about responding to mental health need. So it's not just about we have this program, we've started this program, what we're going to do is link our clients to mental health treatment. We know that there's a real high incidence of needs around substance abuse, that we need to sort of integrate that. And again, this is just showing the continuum that you may be serving people, and you should know through your assessment who may, who may meet criteria for substance use. You may be serving folks that meet criteria for substance abuse, or you may be serving individuals that meet criteria for substance dependence. It's important in your case management model, in your program service model, that you know the distinctions between that you know the interventions that respond based on the severity of the substance abuse problem, and that you make sure that the access to sort of integrated treatment is going to be accessible and available to your clients. And so this is just another important aspect of case management. If you have access to linking your clients to assertive community treatment in your local jurisdiction, you would want to make sure that the practitioners, that team that you're working with, are doing integrated treatment, because you know your clients have a high incidence of maybe substance dependency. If your case manager, if you just have a case manager, a case management team who are coordinating the access of services to your participants, you're going to want to make sure that if it's substance dependency, I'm just going to go back, with a mental health illness that has but the client's experienced limited impairment, then maybe your substance abuse treatment provider is a good entity to provide the services, because they have maybe consulting psychiatry, they're able to prescribe medications to folks. But if you're dealing with individuals that have serious mental illness, and also substance dependency at the sort of highest scale in terms of need. Again, we're just now focusing on the behavioral health needs. Like maybe those people need to be in settings where there is really good co-occurring treatment, whether it's run by a substance abuse agency, maybe it is an entity that provides co-occurring treatment, and you might have providers that do both, so have dual licenses, or a provider that is a mental health provider that has the capacity to do really good co-occurring integrated dual disorder treatment. And so here, in terms of thinking about sort of case management and need, we want to sort of make sure that our programs, our interventions, whether it's very robust for ACT or whether it's a lone case manager, a case management team really have an appreciation of who they're serving and really can link people, because I think most folks are doing sort of linkage to services that are sort of existing in the community, and you want to sort of make sure that you sort of prioritize the folks with the highest need, that they're going to need the most intensive response. And so maybe they need the program that's 3 days a week or 5 days a week or 2 hours a day every day, that they're going to need a more comprehensive intervention than someone who may have substance use, low-grade mental illness, who could just need interaction with treatment maybe once a week, once every 2 weeks, once a month, because they're working, and so it's going to be, we really want to make sure that we really sort of target our sort of access to the services based on folks' need, sort of along the continuum. And one of the things that we sort of know is that it's really important to make sure that the case management folks have skills within all the areas, that they have skills within sort of mental illness, that they have skills also within substance abuse, that's going to be sort of really important for folks to be able to do their job, to respond. I always get a sense of the case manager, the person on the ground who might be linking the person to treatment, following the person up, doing the monitoring for the person, actually probably spends more time with the client sometimes than even the treatment entity. And sometimes when you run these programs and that person had the first relationship with the client as the client came out of detention, out of jail, out of the county jail, out of the juvenile justice system, like the case manager may have been the individual that was more connected to the young person or the adult or the family system in which the client sits, and has a truer picture of the client in terms of all of the needs of the client, and also that the client is more likely to sort of engage with and also share with. And so it's important to think about sort of case management as both spanning systems, whether it's from incarceration to community, and also sort of sharing information across systems about the needs of the clients, particularly if you're in situations where your clients have to go one place for their mental health services, and then they need to go to a different place for their substance abuse services because that's your reality, and you don't have good integrated treatment in the jurisdiction where you're from. And so we know that that's sometimes folks' reality, that then in particular that case management is going to really play a really important role in making sure that both things are addressed at the different locations, if that is your experience in your jurisdiction of how you've linked the person to treatment. And so one of the challenges, so we have sort of at the gold star, the platinum of case management, we have assertive community treatment. We have this mobile team that has all these clinicians that have very low client to staff ratios of 1 to 10. We have this team that's accessible in assertive community treatment 24/7, that can provide crisis response, that's providing ongoing rehabilitation. And then we have juxtaposed that you might be in a situation where you have clients that could really benefit from a really good intensive team, but your program is not funded to that level, you don't have that capacity. I would argue that you could still address the needs of those high-risk clients in a case management program. But you're going to really have to work on sort of leveraging the resources in your community and really having good partnerships with your mental health provider, your substance abuse provider. And what you want to be able to do sort of really from the outset is really have a good sense of what the needs are going to be. And so that the receiving entity, the treatment provider in the community who may not be used to dealing with young people from the juvenile justice system or adults from the jail, adults who are in pre-trial services, adults who are going through a mental health court program, that they have the opportunity to really get to know who you are in terms of what supports that you're providing, as well as who your clients are going to be. And I think that this is where even the lone case manager could be really helpful, that the lone case manager can provide additional capacity to the treatment entity that may feel that they're already stretched. And so the treatment entity may feel, we already have lots of clients. Now we're taking clients from the local jail who are coming to us from the mental health court. But you guys have an additional resource. You have your court coordinator who could be a resource to those, to the treatment provider. You also may have a case manager who could be a resource, who can go to the program, who can case conference with the staff of the program, who can address the issues. I would encourage you guys not just to send people to programs and then ask the program to report back to the court on how the folks are doing, that you really want to use your program resources, even though you don't have a lot of case management and your clients might have really quite robust needs that you want to be addressed by the treatment provider, but really think about the resource that you also bring. Do you know, and it may not just be the case manager, there may be other folks who are part of your court team, other folks who may have other discipline professions, whether it's the public defender, the defense attorney, who may be a resource to the treatment provider. There may be volunteers that are working in your program, or just the staff that are funded through your grant, who become a resource. Because what we know about sort of case management and addressing the behavioral health needs of consumers that are going through these types of programs that we run is that the treatment system sometimes feels put upon. Do you know, with having to receive new clients who have really complex needs. And so if you guys can sort of demonstrate that you are a resource to them as well, I think that that's a way of increasing their capacity as well as their understanding of who your clients are in terms of their high needs, as well as sort of buying in their ability to buy into your program model and what you're hoping to achieve and the outcomes that you're hoping to achieve. And so the ability of your case manager, if you just have one case manager, of your case management team, if you have an intensive case management team, of your ACT team, if that's the entity that you're working with, your integrated dual disorder team, the ability of those staff to also be resources to the treatment entity is going to be a really important thing. And so it means like going out there in the community with the client, when we're working with individuals who have high needs and we're trying to get them engaged in services, the referral has to be a really great handoff referral where you're there physically present. It can't be the telephone referral, which you may be able to do in other situations with other clients who are not high need. When you're addressing high need, you need to really sort of think about how do we really create good systems. We know that where things break down are in transitions. So I referred him, she didn't get there. Do you know the program might be she didn't come? There may be an issue about the high need is transportation. Do you know, like you're in a rural community, we didn't think about that we needed to build into our budget transportation so our clients could get to the program. Do you know, so really sort of think about what are the needs, what are the functionings of our clients in terms of the behavioral health domains, but also in terms of the psychosocial domains, transportation, housing, family stress, poor education, all these things that the clients might have. And you may also want to think about the notion that even in the best treatment doesn't fill up all of the client's time. It just doesn't. And so you may want to think about other resources, rehabilitation resources that your clients should sort of get access to. You know, and I've seen grantees over the years who may be in mental health court programs have the court participants do volunteer work. Do you know? And so it's just a way of getting people prepared to improve their functioning around the ability to arrive at a place on time, to contribute to the community, because you may be selling a population of individuals who the community doesn't want to receive, who are not the easiest to sell. You know, they're not 3-year-old kids that need access to pre-education classes, you know. And so you want to sort of think about what resources do I have in our community that we can really tap. One of the other resources that sometimes we find that people don't think about in terms of addressing people's need, that we think about formal treatment, we think about formal mental health treatment, we think about formal substance abuse treatment, that we don't think about the networks in our communities that are to do with peer specialists, the peer community. And I would charge that most communities have some type of peer community organization, peer-run community in their jurisdiction. It may not be as close to you as it may be over in the next town. There may be sort of travel issues, but that's one where people can get access to social life in a way with other people who are recovering from both mental illness and substance abuse. And so we're not talking about the formal structures that we sometimes think about, or the informal peer structures that we sometimes think about from the substance abuse world, which are due to NA and NA. we're talking about sort of the peer networks that we have. And so there are many peer agencies that are run by people who define themselves as survivors of psychiatric treatment, survivors of the state hospital system, who are engaged in really helping folks with their recovery. And so they run different things like parties that are clean and sober parties, just access to resources of getting people free tickets. Our clients are generally living in poverty. They have high need that can get folks access to leisure activities, and also that can get folks access to peers who are also in recovery, but also not just recovery from substance abuse, but also recovery from mental illness, which we sort of all believe in, that people can get better. And so that might be a place where folks can go when they're not engaged in formal treatment that is also addressing their needs. In many communities, like there may be a cap on how much treatment you can get access to. Like that people meet their treatment thresholds. And so we want to sort of think about in our clients who are at risk of recidivism, like how can we ensure that people are engaged in pro-social things, that we're addressing all the needs, hitting sort of all of the domains. And even in situations where you just do not have, that you don't have access to the most evidence-based services like assertive community treatment that I sort of keep bringing up, which is really this mobile team sort of going around and helping the client connect, that there may be other entities within your jurisdictions that can really help your folks connect to community, whether it's the National Association of the Mentally Ill, which is a family sort of association dealing for parents of people that have mental illness, that they themselves run many groups, networks, support services, know about how to access resources. That might be a resource for you guys. It may be a resource also for the family members of the participants that you're serving, if you're serving adults or juveniles, who can really use support around how to help their client and their loved one in terms of their sort of recovery. So I encourage you to sort of think about sort of the formal case management that we may have in the community that might be funded from mental health, might be funded from substance abuse, that you might be utilizing in your grant, but also think about informal networks to get people access to rehabilitation support. I always, in our program, think about, like, our clients just need someone, an intimate partner who loves them. Like that adult relationship, they don't get access to that, and that's a need that we're not really good at sort of addressing. Like people get well, and then thereafter, what happens when you're well? For us, we have our intimate partner, the person that loves us, that takes care of us, that helps us go, that helps us keep going. And so our clients, as adults and as young people, need to realize that as well. And so just don't focus in on the treatment need. I think it's important. The treatment need is our priority. We want to reduce folks' risk in terms of their behavioral health issues. But whether it's just one person that you have who is a case manager, I think that you can really sort of utilize that one case manager to really span the systems, span the boundaries, really sort of work with your clients around sort of helping them address all of the needs that come with their mental illness, their co-occurring substance use disorder, as well as their sort of psychosocial domains. And so at the conference, this has been the challenge for us about, wow, we want to do mental health intervention, whether we're using case management to help our folks access mental health treatment services or substance abuse services or both services sort of in an integrated way. And now they're sort of saying at the conference, but also you guys, you really want to look at this notion of this made up word of criminogenic risk, and the needs that we need to take care of, those sort of 8 domains that we've heard a lot about over the last 2 days, that put people at risk of being rearrested again, being reconvicted again, violating their community supervision, whatever it might be in terms of your mental health court, your program, and also returning back to detention or incarceration, that you want to sort of take care of those things, like the big 4 as well as the other domains which are related to housing, substance abuse, leisure and recreation, things that within the behavioral health system that we have been used to doing, for many years. But you want to also take care of the antisocial peers, the antisocial personality pattern, and also the criminal thinking. This is a challenge for us because behavioral health case management doesn't naturally tell us what to do, you know, and in many respects we are reading the research, we're reading the manuals, we're reading the books to sort of get guidance, and then we're trying to integrate into our practice. Our ability to do this is going to be first and foremost based on using a validated risk assessment. And so if you want your case management, your integrated dual disorder team, your ACT team, your community provider case management team that's providing the services to your client, that somewhere in the system you're going to have to be using an instrument that's telling you at the individual level what are the areas that put this client at risk for the recidivism, rearrest, reincarceration. So that's one thing that you're going to just have to do. And then you're going to have to educate your case manager, your ACT team, the people providing the services about what risk need responsivity is and how we need to make sure that we use the information that we get from the other assessment. I think the good thing is that the risk needs assessment really provide a really great guide tool. Unlike a regular assessment that you may see done by a psychiatrist or a substance abuse specialist or a licensed mental health clinician that looks at someone's domain, like saying in a psychiatric eval that this person has paranoid schizophrenia, polysubstance dependence, they're homeless, they have a GAF score of 45, doesn't really provide a clear guide. The psychiatrist's recommendation may be client needs mental health treatment. You know, the psychiatrist is not sort of saying to us, client needs, you know, like mental health treatment every day, you know, or client needs day treatment or partial hospitalization. It's an overview assessment. It's an assessment of sort of diagnosis and functioning, and it's sort of saying meets criteria for serious mental illness, should engage in mental health treatment. You know, the assessment that we do around sort of substance abuse that may be integrated into your overall comprehensive assessment may, again, rate the person in terms of having cocaine dependence, opioid dependence, whatever, polysubstance abuse, whatever it might be in terms of diagnosis. So we know it's severe, you know, like we know from that assessment that the person, you know, was using substances every other day for the past 6 months before they were arrested on the instant crime that gets them into our program, but also that the client maybe used a tool that asks folks around motivation, that the client's really motivated to get treatment. The client may, during their detention, had some period of abstinence during their detention and is returning home, but you guys have created a case plan that talks about the sort of substance abuse treatment that the client's going to get in an integrated way with their mental health treatment. And so I would suggest that the use of a validated risk assessment provides really good guidance to whether it's a sole practitioner case manager who's a bachelor's level case manager addressing your high need clients, or an ACT team, you know, with all those folks, psychiatrists, nurses, and social workers working together in a small ratio, that this provides good guidance both to the case management entity, as well as your treatment entity, because it's going to show, wow, this person is really is scoring high for substance abuse and antisocial personality patterns, as well as for family and marital difficulties. Or it may show that the client is scoring high for antisocial associates and is scoring low in every other domain. So it sort of gives you a tool around sort of guidance, I would argue, that the risk assessments do that other assessments that we sort of use in the field of behavioral health don't necessarily do. Sometimes they do, but not in a very unified sort of fashion. But the challenge for us is not the risk assessment. That's the easy part. And so actually deciding what assessment to use and then starting to use it and then making sure that you're using it in a validated way, I think is the easy part. It's matching in an individualized way, whether you call it case plan or treatment plan or service plan, the interventions, how much the person is going to get of a service, as well as the objectives that you have around each of the risk factors. And so if your client scores high in terms of hanging out with other people that are involved in the justice system that put them at risk of that puts them at risk of recidivism, like what would your objective be in the service plan? So that your case management defines it. Is it going to be that Anne-Marie is over the next 6 months not going to hang out with any antisocial people? Is that your objective that you're going to sort of work in your case plan? Is that real? Is that meaningful? And so for us, the challenge is what are we doing at the program level, at the case management level to sort of really intervene at the risk need? And it might be that you run that you have access to cognitive behavioral training groups that are going to allow your client to have sort of exposure twice a week, once a week for 2 hours to this group process, which is addressing the criminogenic risks and needs that have been identified for the use of a validated instrument. Or it could be that your case manager, your treatment provider is in individual sessions with that client, really addressing those risk factors. Who did you hang out with yesterday? How did you meet him? Oh, he's your friend from where did you meet him? I met him in jail and he's a really nice guy. Oh, that's interesting. And so we have to sort of think about how we integrate this practice. I would say that the integration of this practice on the ground level for both case management and treatment teams and treatment service providers is very challenging. I think that when we were attempting at Cases to roll out this and our staff were sort of trained in the use of the risk assessment, they were saying, but we're clinicians. We went to school. We were trained on how to assess folks. And now you're saying use a standardized instrument that's going to sort of point us into the roadmap of what we're supposed to do, what we're supposed to target. People were like, well, I was just trained to do that from this unstructured interview of the client. So we're not saying sort of throw out the unstructured interview, but use a validated instrument and then really target those things and really think about in your case plan how you've integrated those things. And I think that the validated instrument really sort of helps us to respond to the high-risk clients. And so the high-risk clients are those that are scoring high in those dynamic risk factors on the risk assessment, as well as having an overall risk score. And so you can score medium on a risk assessment, but be high in those dynamic domains that you need to target, and we're not going to ignore that. If you score low, it's not so important for intervention, but medium, high, or very high. We want to make sure that our service delivery, whether it's case management, is really sort of targeting that. And there is some research. Jennifer Scheme had looked at probation officers, and what she found is that when probation officers just in their interactions with their probation clients spent 15 minutes addressing the criminogenic high needs of the clients, that they had an impact on recidivism. And so you can do it in both the individual work, and so sometimes case managers are taxis. They're driving people to treatment programs. And so you're in the car with someone, you're on the bus with someone, you're waiting in the benefits office with someone. That in case management, you can take every opportunity to focus in on what you're doing rather than saying to your client, oh, here's the paper, read it, we've got to wait for an hour. So you can use that time in sort of a meaningful way. And for us, I think we just have to, in our programs, be creative about how we use case management, even when we don't have a lot of resources, a lot of time, and when we don't have the evidence-based program. It doesn't exist. We have to just think about, in case management, it provides a great opportunity to take some of the principles and sort of use them. So on that note, I think I'm going to stop and ask if there are any questions or observations, or if folks wanted to share with us some of their experiences on how they've sort of tackled using case management to both integrate addressing mental health need, substance abuse need, and also criminogenic need.
I have a question. Is there research showing what our caseloads are optimal at?
All right, so the question was about sort of the optimal caseload. So you're talking about the ratio of staff too. And so...
especially taking in consideration of the high-risk, high-need demands.
Right. And so if the higher risk your client, the more needs your client have, the lower your ratio should be. But each program has its own reality, its jurisdiction has its own reality. But I would argue that good practice sort of tells us ratios of 1 to 14, 1 to 15, 1 to 25 for high risk, high need folks. It would not be appropriate, I would argue, to have ratios of 1 to 50 when you're dealing with folks who are high need, high risk. I think that you're sort of setting yourself up for a challenge unless someone is saying, wow, that's a really low ratio. Unless you know that within that model, the areas are being addressed, as I said, do you know? And so the more access to other services your clients have, I would say that your ratios could increase. But I think that you really want to use case management in these programs to add additional capacity for your treatment providers to manage the high need, high risk of your clients as well.
Are your case managers the ones doing the assessment tool to determine the risk?
Right, so in our program we have how we're just organized. It's a social worker on our ACT team that does it, so it's just one person, and then we have a social work supervisor and another social worker on another program who does it. And so if we had larger ratios of people that we're serving, we would have more people doing it. And so in our youth program where they use the instrument, the youth program is not serving folks that have mental illness. All the case managers are trained to use the tool.
Do you think it's appropriate if we work, because we work closely with probation, to utilize their tool if they're already doing it, as long as we have permission to share?
Exactly. I would suggest that don't duplicate work that's already being done, yeah.
Are your social workers licensed clinicians or are they just MSWs?
Licensed clinicians.
And I'm running in, we're just ending our 2-year grant and we're running into sustainability, and we've had state changes. I'm in North Carolina and everything's being obviously taken over by Medicaid, and I'm being told, and I don't know if this is for reasons of let me just say, I'm being told that we don't need a licensed clinician, that we can just have an MSW to do the groundwork. And I'm wondering if it is because of territory. And we had a licensed clinician, and of course the the payment for that salary is a little larger, but I'm being told by the mental health entity that we don't need a licensed clinician, you don't need license. We really did a quick handoff model from law enforcement as they were coming in, not necessarily going into the jail, but from 911 calls, and we would do follow-ups. It really helped to have that licensed clinical social worker, but like I said, I'm being really told that we don't have to have that. But you highly recommend the clinical piece of it.
I think it depends on what pieces of work the person is doing. So what's in the scope of their professional standards. And so for us, the work that our staff are doing is work that we're billing Medicaid for, and so they need to be licensed. And so there are other activities in case management that don't require a licensed clinician. And so if so I would encourage you to sort of think about that. Does it really require? Because it may be that the licensed clinician was doing this quick handoff, but was doing continuous assessment. Do you know of the folks who were being handed off, or was doing, I don't know, crisis intervention work that only a licensed clinician could do and you felt satisfied with? And there were episodes where the clinician had to assess whether the person needed to be hospitalized, might be, and so really it required a licensed person. So I'd encourage you to think about, are there aspects of the work that only a licensed clinician can do? There are aspects of, when we had started, our social workers did everything when we were just doing a case management model. So we did take you to the benefits, and so after office, and take you to the treatment provider, and provide crisis intervention, and all these things were just specs of, again, licensed social workers. And over time, me as a manager now, as a program administrator, I'm not going to pay for a social worker to take someone to the benefits office. You know, so we have case managers that do that, bachelor's level. We have peer staff that do that. Do you know, I have to think about how to effectively and efficiently use the resources within our budget. You know, and so, but clearly sometimes external mandates trump what we might think is best practice, unfortunately, yeah.
Is ACT a branch, an extension of your CSB? Are they a private, or I'm not familiar with that?
Right. So assertive community treatment is a model. It was established in Wisconsin in the 1970s. It's actually one of the most researched and validated evidence-based models for providing in an integrated way both treatment and case management to people with serious mental illness who are high utilizers of hospitals. And so many states have ACT teams, but some states don't. Do you know? And so, so assertive community treatment, it's a mobile treatment team. And so what the model is it's basically your inpatient psychiatric ward. Psychiatrists, nurse, social workers who work in the community with a defined number of clients, but they do all of their work in the client's home. So the psychiatrist goes to the client's home, the nurses do. The onus is on the ACT team to engage the client. It's not where the individual is going to a community mental health center to get their treatment. And so so that is a big challenge for many states. There's an ACT association. You should look that up on the website. I think if you just Googled ACT association, it's going to come up. It's going to show you where, which states have ACT. Some states like New York have made ACT a Medicaid reimbursable service, so we're able to do statewide rollout. Eric, who's next door doing another breakout session, he's from Idaho. They rolled out like ACT in the state of Idaho as well. You know, so there are many states that are using ACT, and it's a cost-effective model for your high utilizers of mental health, hospitals, and now jails as well. Yeah.
Hi, this is great. Can you say a little bit more about the rubric that is being promulgated a lot at the conference, and how, you know, one of the things we struggle with in our state with specialized case management services is case management is still really doing treatment and rehab options and things like that, but how do we think about integrating with what probation is doing and making those lines of distinction between more intensive supervision and the like with case management?
Great question. And so I think that in case management, it's a resource, and so in addressing criminogenic need, I would argue in an integrated model, if someone has a risk assessment, if they have assessment of mental health, if they have assessment of substance abuse, that the probation officer could be doing a lot of the criminogenic responses, and your case management around mental health and substance abuse could be doing a lot of the behavioral health. But each folks need to know what the other is doing. And so that might just be a response that you create that helps facilitate the effective use of resources, the efficient uses of resources, but you've got to be communicating. You've got to be talking about it. It can't be parallel like we've seen when people were getting mental health treatment and then this parallel substance abuse treatment. You need it to be integrated. And so there may be protocol systems that you work out with your probation staff around how are we going to sequence this? How are we going to know when you guys are working on these big four? How are we going to reinforce it? And so, you know, I would suggest that you can use resources to do aspects of it, but you've got to create the integration in your protocols, in your communication, and each staff knowing. So one of the ways that you may create integration is by having just one case plan. And in your case plan, it can be, you know, Anne-Marie is the case manager is responsible for doing these things, but we know Jill as the probation officer is doing these things. They're regularly meeting. We're doing service plan review of the status of the client in an integrated way. And that you can do by sitting down with the client together and reviewing the status, the progress that they're making. And but ideally we would want to make sure that everyone knows what everyone else is doing, but also that each person has the skills of the other person as well. That would be the high echelon of the integration.
That's a great answer. I guess just one question sort of in the weeds, though, is when you're working with a client and you're working on the clinical side and you know they said I was using cocaine last weekend or whatever, how readily do you communicate that to probation, where probation might not know until they do a talk screen?
Right. And so those protocols you need to establish with your clients and your other entities from the beginning. And so this is sometimes a really, really big challenge. And so I can just give you sort of the experience of our program. In our program, we give clients their rights, their responsibilities, and we also give them information from the outset when we're screening them about what information will be shared with the other entity. And so that the client is buying into that from the beginning, that it's not going to be a surprise to them later on where your therapeutic trust with the client is diminished because they feel that you sold me out, that you gave information that I wouldn't want you to have given. In these programs where we're doing the intersection of criminal justice, juvenile justice, and behavioral health, we really need to think about those protocols from the beginning. The issue of substance abuse and relapse is always going to come up. You need to really think about that really closely, about what will be communicated and when.
So do you share everything?
We do, but not everything. And so we share everything, and so we've created protocols around the stuff that the court's going to need to know. So the court's going to need to know about substance abuse. That's important. But if you're working with someone as a clinician and our psychiatrist working with someone, one of the social workers working with someone, and they disclose maybe a significant history of trauma, it just may not be relevant to the court. Do you know? And so the good protocols around communication, just think about in terms of all those public safety domains that criminal justice folks, prosecutors want to know about, judges want to know about, and probation, parole, whoever pretrial services want to know about. And then think about all the clinical private stuff that clients may tell a therapist, and that therapist, which won't leave that room. It's not necessary to leave the room to confirm to the criminal justice entities, community supervision, probation, or parole, the client's engaged. Then, like we're addressing their risks, they're not doing anything that's of sort of worry.
In our system, we have for the UA line, we give everybody that comes to the program a color, and then every morning between the hours of like 6 and 8, they're supposed to call the UA line, and then if their color is called that day, they go in UA. Just information that is supposed to be shared with everybody. We constantly are emailing everybody. We're emailing therapists, we're emailing the probation officer, we're emailing the judge, court coordinator, data clerks, whoever it is that we need to notify, we keep in touch via email. Things that we kind of share in our program, like you were saying, do you share everything? Well, I don't need to know specific details if you were sexually abused, how you were sexually abused, but maybe that there was that traumatic incident that did occur. And I think the fact that there's that important factor of, yes, there is a traumatic history that has happened to this individual. I don't need to know exact details, but just the fact that it did occur. And that's all I need to know, because I don't need the individual to be reliving the moment over and over and over. I mean, this person's 30 years old, they've already had to share their history and share the story with 20 other people. I don't need to know it. I just need to know there is the traumatic event, and then that's treatment, that's a treatment issue that they adjust in treatment.
Thank you. And it raises a really important point about timing is everything in communication, particularly around trust. And so the moment you've not shared something that puts a participant who a judge, a prosecutor has agreed, an adjudicator in the court system has agreed to allow you to have in the community, you've just diminished trust. And so I think that that's really an important point for us to know about the timing as well of the communication, not after the fact, but, so clients need to know what's going to happen. But the other point about working with high-risk, high-need folks is the notion of we know the high-need, the high-risk are more likely to fail. That's who the sort of population is. And so relapse is just going to be a reality of what we're experiencing, but you want to have a response to that. So in our program, we're going to experience clients relapsing. What's our response to that? What's our treatment intervention? What's our supervision intervention to address the risk that it doesn't result in rearrests, out with other people that are getting high and doing other crimes. So we want to make sure that we have a response to the risk issues that appear.
Right, and pointing out triggers. Like we have a lady in our program who her mother was the person who was sexually trafficking her to people who were dressing up in Santa Claus outfits. So, I mean, to this day, she cannot see a Santa Claus. So it's like recognizing what triggers of the individual, especially Christmas time, and there's Santa Clauses everywhere. You have to be specific to that individual's needs.
Hi, I'm just curious to find out in regards to your program, once a client that you work with has completed the criminal justice system and has had some significant recovery, how long do you typically work with a client after that? Do you just continue to work with them? Is there steps towards self-efficiency where you say, okay, you're done, you're good to go, you're on your own?
So there's a couple of responses to that. We do use the ending of your court participation as a time when we begin to look at what discharge planning, some folks refer to that as aftercare, someone might need. But because we're also licensed by the New York State Office of Mental Health, we have to follow their criteria about how someone leaves an ACT team. And so if someone, in terms of their needs, their behavioral health, their mental health and substance abuse needs, may have finished court but still needs ACT services, we have to keep them. But for many of our clients, like finishing court demonstrates the things that you've identified, that they're on this pathway to recovery, that they've established abstinence from substance use, that they're now housed, that they're in a rehabilitation mode in their life. And so for each person, we engage in utilization review and discharge planning with the client about what's going to happen after they finish with us. And so for generally, the majority of our clients are going to step down mental health outpatient clinics, mental health centers to get their treatment, see a psychiatrist once a month. Many of them are also continuing with case management, but not ACT case management, just a lone case manager. Now in New York City, we're calling that, because of the reforms in the Affordable Care Act, we're calling that behavioral health care coordination. So there's actually this shift, I didn't talk about it, from case management to care coordination that folks need to get sort of ready for as well. And so folks are stepping down to a care coordinator, and again, it's based on need and functionality of how much they're going to get. Some people are having once a week contact, some people are having sort of less frequent contact. And so because we know for a high-risk, high-need population that transitions are difficult periods of time, we follow folks both with direct contact with the client and the new treatment provider, the new case management person, for a period of up to 3 months after they've left. So we follow folks for 90 days.
So do you have a response? So in that following 90 days, say they've completed all of their court requirements, in that 90 days, if something triggers, that there's something going on, do you ever pull them back in?
Into ACT, no, but we would work with the new treatment provider because we know more of the clients. On average, they've been with us for about 2.5 years. So the client's going to a mental health center, the client's going to a case manager. And so our psychiatrist and our team leader, the other day I was in a meeting with them, and they both got a text at the same time from one of a client who we discharged, I think, about 6 months ago. And it was a distressing text, and someone who has bipolar disorder and clearly was, again, having a manic episode. And so they both, the team leader went and called him, and sort of, first she texted him, "Are you okay?" And he texts back, "No, I'm not." Because many of our clients communicate by text. I don't know if you guys have that same experience. I'm like, well, you're texting the client. And so she was able to call him and speak to him, and she actually, he was going to his clinic. We just don't know if he stopped taking medication, but she actually just called, in our continuum of care, we have mobile crisis. So she called the mobile crisis team to go to his house to see, and then she called the clinic therapist, and she called the case manager to say what was doing. And so we've not really had people come back because the treatment didn't work afterwards, but we sometimes find sort of an interesting thing, like it could be a year after they've left. Like clients are with us for so long, I think this 2.5 year period, that they really do establish an attachment to the team. And also because you're doing something that's very unique, you get someone out of detention or jail, like people feel sort of beholden to that relationship and they're sort of thankful. But we work with the new treatment entity to sort of help and support the client. Any final questions or comments people wanted to share?